Well, in this week's Cardiology Countdown, we have a look at sudden cardiac death in congenital heart disease, a look at what blood pressure targets should be in patients with diabetes, and a look at whether adding an anticoagulant in the setting of acute coronary syndromes is beneficial. So beginning with an observational study in patients with congenital heart disease, there's a study of 25,000 patients that came from 3 different databases looking at the issue of sudden cardiac death. About 5% of patients in this registry died, of whom 20% of those were sudden cardiac deaths. And they looked at what were the predictors of sudden cardiac death. They found that having a history of SVT was a component. Also, left ventricular dysfunction, although they called it systemic ventricular dysfunction, as well as pulmonary ventricular dysfunction, so RV usually, were both independent predictors of sudden cardiac death. Also long QRS duration as another factor, and QT dispersion. And thus they concluded that many of the risk factors were similar to what's seen with standard patients with left ventricular dysfunction, but that this carries over into congenital heart disease depending on which ventricle, and thinking actually about both ventricles as a way to risk stratify for sudden cardiac death. And so bringing in a new concern to monitor for in congenital heart disease. Next up is a study from the archives that does a meta-analysis at what should be the blood pressure targets in patients with diabetes. This is a study that combined data from the ACCORD blood pressure arm as well as the HOT trial and ABC2V study and 2 others. That looks at a very hot topic of what blood pressure target should we be going for. They found a non-significant reduction in mortality in the more intensive lowering of blood pressure, aiming for a lower target. The relative risk difference was 0.76, although this wasn't significant, with a confidence interval going up to 1.05. Still a bit of a trend to many people's eye. MI was not different, a hazard ratio of 0.93, but stroke was, with a hazard ratio of 0.65. And so they noted this is a 1% absolute reduction in stroke, which these authors characterize as modest. But I think that is the state of understanding, that more aggressive blood pressure lowering seems to have an effect on reducing stroke and less clear effects on mortality or MI. And the number 1 pick is another paper from the Archives of Internal Medicine looking at the effects of adding an anticoagulant to dual antiplatelet therapy, largely in patients with acute coronary syndromes. There were several smaller trials amongst the 12 included, and the 2 large trials were Appraise 2 and the Atlas TIMI 51 trial. They found overall a big increase in bleeding, a 3-fold increase in bleeding, with the same about for each different severity, major bleeding or minor bleeding. They found a significant reduction in the composite endpoint, cardiovascular death and MI or stroke, and of stent thrombosis, interestingly, in the trials that assessed that. But when adding major bleeding to cardiovascular death and MI or stroke, the effect was neutral overall, with hazard ratio of just 0.98. And so they argued that the net benefit really didn't seem to be there when putting up those 2 type endpoints. There have been reductions in mortality seen with the very low dose of rivaroxaban in the Atlas TIMI 51, and so not addressed here is the dose of the anticoagulant, whether a very low dose anticoagulant as opposed to full dose anticoagulation may be of benefit. So for this week's Cardiology Countdown, I'm Chris Cannon.